Sir, good morning, sir.
Morning, Priyanka. Prasad, we can start.
Thank you, sir. A very good morning, all. Today's topic of discussion will be rickettsial infection. It is not something that we see daily in our day-to-day practices. It is a very rare infection, but a re-emerging threat in India. So my aim with this discussion is to outline for a better understanding of the epidemiology, pathogenesis, clinical manifestations, and to discuss the recent trials on the management of the rickettsial infections, especially scrub typhus. So starting with a small made-up case scenario. A 30-year-old woman, farmer by profession, presented with fever of 10 days with non-productive cough of 5 days and complaining of breathlessness. On examination, she was febrile, dyspneic, had an scar in the right axillar region with the petechial rashes all over the body. Routine investigations done revealed thrombocytopenia, transaminitis. X-ray showed bilateral reticulonodular interstitial opacities in the lower lobes before the treatment. This was the X-ray on presentation. After 2 days, her hemodynamics and breathlessness worsened, developed altered mental status, therefore was intubated and was shifted to a tertiary care center, and a repeat chest X-ray done there was this with the increase in bilateral infiltrates suggesting of an ARDS picture. So what should be our diagnostic approach and management? I hope that by the end of our discussion, we will be able to formulate or construct a differential diagnosis and a management plan for this patient. So the outline of our discussion will be, as I said, we'll be discussing only a few types of rickettsial infections, its pathogenesis, clinical manifestations, diagnostic approach, and management. The knowledge of rickettsial infections, that is especially scrub typhus in India, had increased during the World War II. It is an important cause of acute febrile illness, which is often ignored and is a re-emerging threat in India. Endemic areas of scrub typhus in India are northern, southern, and Himalayan states. However, outbreaks were reported from all over India. These are the small gram-negative bacteria and an obligatory intracellular parasites transmitted by arthropod vectors. They are primary parasites of arthropods, often found in the alimentary canal of lice, mites, ticks, and fleas. In vertebrates, most commonly, they infect vascular endothelium and reticuloendothelial cells. The common genera causing rickettsial infections are Rickettsia and Orientia. Rickettsial infections are again divided into two groups for our convenience, the typhus and spotted fever group. So coming to the classification, just a broad classification, brief classifications, typhus groups and spotted fever groups. Typhus groups includes epidemic typhus, murine typhus, and scrub typhus. Epidemic typhus, the causative agent being Rickettsial proboscis, with insect vectors of louse and mammalian reservoirs are humans. In murine typhus, caused by Rickettsia typhi, insect vectors of flea and reservoirs being rodents. In scrub typhus, Otsutsugamushi, Orientia tsutsugamushi, with vectors mite and mammalian reservoirs being rodents. Similarly, in the spotted fever group, Indian tick typhus by Rickettsial conuri, Rocket Mountain fever by Rickettsial rickettsian acari, with the vectors of ticks and mites, and again reservoirs being rodents, dogs, and mice. So this is a brief classification. Now coming to the epidemiology, it is especially scrub typhus is distributed throughout the Asia-Pacific rim. The endemic areas are the so-called Tsutsugamushi triangle, which extends from Korea, China, Taiwan, Japan, up to Pakistan, India, Thailand, Malaysia, and to the tropical region of Australia. Incidence, it is up to 1 million cases are reported annually in Southeast Asia alone. Farmers accounted for 2/3 of all reported cases. Age groups in adults highest in aged between 40 to 60 years, but young children had higher rates of infection than in adults. Higher incidence is seen in monsoon and post-monsoon season. So if you see at the Tsutsugamushi triangle, this is the Tsutsugamushi triangle that we are talking about. It is extending starting from North Japan for far eastern Russia to up to India, Pakistan, and Afghanistan, and extending up to the northern Australia. Almost 1 billion population, more than 1 billion population are at risk, and 1 million cases are reported annually. Coming to the pathogenesis, the serious clinical manifestations of rickettsial infections is primarily due to the infection of endothelial cells leading to cell dysfunction or injury. In typhus and spotted fever groups, predominantly vascular endothelium is involved, especially that of the lungs and brain. Organisms enter the cell body by endocytosis, escapes the endosome into the cytoplasm using hemolysins, where it proliferates, and cell-to-cell spread occurs by lysis of the cell in typhus group, whereas in spotted fever groups, it is by actin-based motility. So in this image, as you can see, the rickettsial infection enters the cell by endocytosis, forming an endosome, and after this, it evades the endosome using hemolysins, enters the cytoplasms, where it proliferates, and in the cytoplasm, intracellularly in the cytoplasm, it proliferates, and from here by two ways, it spreads to other cells. That is, one is by rickettsia overwhelming the cell, causing lysis, usually seen in the typhus fever groups, whereas rickettsia are transferred to the adjacent cells by actin reorganization and philopodia formation, and this way they enter into the other cells. So this is how they spread from cell to cell. Now this widespread causes endothelial cell dysfunction, leading to multi-organ failure like pulmonary edema, renal failure, and variety of CNS manifestations. Now coming to the just a brief discussion about epidemic typhus and Rocky Mountain spotted fever. Epidemic typhus caused by Rickettsia prowazekii is transmitted from person to person by body lice. It is associated with wars and poverty, where individuals live in close contact with poor hygiene. Manifestations include a rash that is initially macular, progressing to a petechial maculopapular rash on the entire body, except for the face, palms, and the soles. So in epidemic typhus, we don't see the rashes on the face, palms, and soles. But whereas in Rocky Mountain spotted fever, it is caused by Rickettsia rickettsii, is transmitted to humans by dog ticks. It is most common in the southeastern and south central United States. It begins as a non-specific severe illness with fever, myalgias, and gastrointestinal distress, and then progresses to a widespread macular, then petechial rashes that can even involve palms and the soles. So now coming to the discussion about scrub typhus, we would like to have a little detailed discussion about scrub typhus because it is the most common rickettsial infection seen in India and a re-emerging threat. So it is the causative organism of scrub typhus is Orientia tsutsugamushi, most common rickettsial infection in India. It is transmitted through larval mites called chiggers of Leptotrombidium mite. The chiggers feed on the rodents, and humans are the dead end of this infection. Majority of cases occur in monsoon and post-monsoon months. People at risk of the disease are those who come in contact with larval mites, either due to profession, that is farming, or due to leisure activities like household grass work and all. So life cycle of Tsutsugamushi, as you can see here, it all starts from the eggs, larva. The adult transmits the infection, has the transovarian transmission of the infection to the eggs. Eggs hatch out to be a larva, and these are the ones infecting the humans. And at the bite side, they form a scar due to the endothelial injury and the macrophage activity. They form an scar here and also causing regional lymphadenopathy, which is also the hallmark sign of pathogenesis of Otsutsugumushi. Now coming to the case definitions, suspected or clinical case is a case with an acute undifferentiated febrile illness for more than 5 days with or without a scar, or fever less than 5 days with a scar, along with other clinical features like headache, rashes, lymphadenopathy, and multi-organ involvement, should be suspected as scrub typhus. Probable case, a suspected clinical case with titers of more than 1:80 in OX2, OX19, and OXK antigen by Weil Felix, or more than 0.5 optical density of IgM by ELISA, are considered as a probable case of scrub typhus, also for spotted fever. A confirmed case is by Rickettsial DNA detection in eschar samples or whole blood by PCR technique, or raising antibody titers on acute and convalescent sera detected by immunofluorescent assay is considered as a confirmed case of scrub typhus. Now coming to the clinical features, in the first week of illness, most common initial presentation or onset is with acute febrile illness. Other associated features being myalgia, conjunctival congestion, headache, nausea, vomiting, lymphadenopathy, especially regional near the eschar site, is a hallmark sign, and hepatosplenomegaly. An eschar can be seen in early diseases and is useful diagnostic clue in scrub typhus. However, its frequency varies from 7 to 97%. Rash usually seen after 3 to 5 days of onset of symptoms. Initially starts as a macular rash, which subsequently becomes maculopapular and petechial rashes. So this is an eschar with the typical central black scab suggesting a cigarette burn on the skin. And the eschars we can find, usually they are found in the unhidden areas like neck, axilla, and also groin. So usually we find the eschars in the unhidden areas of the body. So most of the times there is a high chance that we miss these eschars and also we miss the diagnosis. So second week of illness, usually we see the complications in the second week of illness. Pulmonary complications being pneumonitis, acute lung injury or ARDS, pleural effusions can be bilateral and they can be transudates or exudates. Hepatic, causing hepatitis. Hematologic, you can see thrombocytopenia, DIC, hemophagocytic syndrome, leukocytosis or leukopenia, and anemia can be seen. Cardiac complications, you can see relative bradycardia, myocarditis, heart failure, pericarditis, and acute myocardial infarction can be seen. In neurological manifestations, meningoencephalitis, encephalopathy, focal weakness, neck stiffness, immune-mediated CNS, like CNS complications like optic neuritis, AIDP or GBS, mononeuritis multiplex, cranial nerve palsy, and also seizures can be seen. In renal complications, AKI, and other complications being transient adrenal insufficiency, acute abdomen, polycirrhosis secondary to the vascular endothelial injury and also mimicking this capillary leak syndrome, septic shock, and MODS, multi-organ dysfunction. So these are the complications most commonly we see in the second week of illness. Now coming to the diagnostic approach, first is by clinical suspicion, when to suspect scrub typhus. The high index of suspicion is needed for those presenting with acute undifferentiated febrile illness in endemic areas should be suspected. A history of travel or visit to a forest, grassy area, or seashore, and 2 weeks later developing, that is as the incubation period of scrub typhus is 6 to 20 days. So 2 weeks later, someone developing febrile illness should prompt a suspicion. In patients presenting with acute febrile illness with rash and complications are difficult to distinguish from other causes like dengue, malaria, leptospira, enteric fever, etc. Simply other tropical diseases. In patients with capillary leak syndrome may be confused with dengue. Therefore, clinical scores for distinguishing scrub typhus from dengue are being updated but needs validations. In a multi-centric study done in patients presenting with undifferentiated fever from 2 to 14 days duration, revealed that in southern states of India, 35.9% had scrub typhus, northern states had 14.42%, and other states had 10% scrub typhus in patients presenting with undifferentiated fever. So coming to the specific investigations that needs to be done in scrub typhus or Weil Felix, this test is because the sharing of the antigens between the Rickettsial and Proteus is the basis of this heterophile antibody test. It demonstrates the agglutinins to Proteus vulgaris strain in OX19 and OX2 antigens and Proteus mirabilis of OXK. So though this test lacks high sensitivity and specificity, but still serves as a useful and inexpensive diagnostic tool for laboratory diagnosis of rickettsial disease. This test should be carried out only after 5 to 7 days of onset of fever. Titers are of 1:80 is to be considered as a possible infection. However, baseline titers needs to be standardized for each region. IgM and IgG ELISA. ELISA techniques, particularly IgM, capture assays for serum are probably the most sensitive tests available for rickettsial diagnosis, and the presence of IgM antibodies indicate comparatively recent infection with rickettsial disease. In cases of infection with Otsutsugamushi, the scrub typhus, a significant IgM antibody titer is observed at the end of the first week, whereas IgG antibodies appear at the end of the second week. The cutoff value is the optical density of 0.5. Baseline titers needs to be established keeping in view the regional variations. Polymerase chain reaction PCR technique. It is a rapid and specific test for diagnosis. It can be used to detect the rickettsial DNA in whole body, in whole blood and eschar samples. The PCR is targeted at the gene encoding the major 56 kDa and 47 kDa surface antigen gene. The results are best within first week of blood samples because of presence of rickettsiemia. It's Otsutsugamushi or Rickettsial typhi, and Rickettsial prowazekii in the first 7 to 10 days. Immunofluorescence assay. This is a reference serological method for diagnosis of rickettsial disease and is considered serological gold standard. However, cost and requirement of technical expertise limits its wide use. Therefore, it is recommended only for research and in areas where seroprevalences of rickettsial diseases has been established and a reference facility is already available, which has the necessary expertise required to conduct these tests. Biopsy of an eschar. The pathognomic hallmark sign of this eschar is the lymphohistocytic vasculitis, that is the focal areas of cutaneous necrosis surrounded by a zone of intense vasculitis with perivascular collection of lymphocytic and macrophages. This typical finding can be diagnostic of scrub typhus even when rickettsia are not detected by IFA. Cultures, again, available only at few centers. Specialized facilities with rigorous quality control and lab safety measures are required as it is highly contagious. No supportive laboratory investigation. Again, coming back to the specific lab investigations, which is the ideal test to be done, there is a huge debate, but as already discussed, Weil Felix is easier to perform in all the centers, and whereas IFA and PCR being the gold standard to diagnose and have a high diagnostic value for scrub typhus, but cannot be performed in all the centers. So veil Felix can still be an choice of investigations in especially in a resource limited settings for diagnosing scrub typhus. So supportive laboratory investigations. Hematology, we can find the total leukocytes during early course of the disease may be normal, but later in the course of the disease, the WBC count may become elevated to more than 11,000. Thrombocytopenia less than 1 lakh is seen in majority of patients. Biochemistry, we can see that raised transaminases levels causing hepatitis, and imaging, as already I have shown a few images, and chest X-ray, we can see bilateral reticulonodular opacities, and if indicated, we can also opt for neuroimaging, CT or an MRI. Now coming to the differential diagnosis, usually the rickettsial fevers, they mimic most of the tropical fevers like malaria and dengue. So malaria and dengue share common clinical features and similar endemic patterns with scrub typhus. Leptospirosis is a common disease in some tropical regions where scrub typhus also occurs. The scrub typhus without eschar and rashes but with GI distress might mimic Salmonella typhi in areas where typhoid fever is more common. So always we have to keep in mind these differentials whenever we are thinking about scrub typhus as a diagnosis for our patients. So features differentiating scrub typhus from other tropical infections, especially favoring features favoring the scrub typhus are eschar with regional lymphadenopathy, fever more than 8 days, CRP of more than 32, transaminitis, and defervescence within 48 to 72 hours of specific therapy. Now, those not favoring or more in favor of other differentials are bleeding manifestations, which is most commonly seen in dengue, leukopenia, again more commonly seen in dengue, thrombocytopenia in dengue, bilirubin of more than 2 mg per density liter can be seen in malaria and hepatitis A, transaminitis or AST more than 500 usually seen in dengue, and ALT more than 500 in hepatitis A. So these are the some few features that you have to remember when you are thinking of scrub typhus, especially eschar, regional lymphadenopathy, and defervescence within 48 to 72 hours of specific therapy are the things which you have to keep in mind when we are suspecting scrub typhus. So key treatment study, there are many treatment studies done, not many, sorry, there are a very paucity of studies actually in scrub typhus. So there are, I have just mentioned a few trials trying to compare with the doxycycline and azithromycin, chloramphenicol, and also rifampicin and quinolones. Just a few studies, and also we will discuss about the latest NEGM trial, INTREST trial published in the NEGM. So these are the old trials. First one, chloramphenicol versus tetracycline, done by Sheehy et al. In 1973. The type of study was a clinical trial. Randomization was unclear, and the key finding of the study was tetracycline was found to be superior to chloramphenicol. Then in 1978, doxycycline of 200 mg single dose versus tetracycline 100 mg to be taken 4 times a day for 7 days was compared in a randomized control trial, and they found that the single dose of doxycycline was as effective as conventional course of tetracycline. In 1995, again in doxycycline 100 mg twice a day for 3 days versus tetracycline 100 mg to be taken 4 times a day for 7 days were compared by Song et al. In a randomized control trials, and he concluded that short course of doxycycline as effective as conventional course of tetracycline. Now in 2004, Kim et al. Compared azithromycin 500 mg single dose versus doxycycline 200 mg daily for 7 days in a randomized control trial, and he concluded saying that azithromycin single dose is equally effective as doxycycline 7-day course, defervescence slightly longer with doxycycline, less gastrointestinal adverse effects with azithromycin. So Kim et al. In 2004, he recommended azithromycin to be better or superior over doxycycline. In 2007, Fimda et al. He compared azithromycin 500 mg daily for 3 days versus doxy 200 mg daily for 7 days. And he concluded saying that azithromycin 3-day course equally effective as doxycycline 7-day course. Again, differvescence was longer with azithromycin, less GI effects with azithromycin. So Kim et al. And Fimda et al. In 2004 and 2007, they concluded saying that azithromycin is superior to doxycycline. And Kim et al. Again in 2007, he did a randomized control trial comparing telithromycin 800 mg daily for 5 days versus doxycycline 200 mg for 5 days. And he concluded that telithromycin is as effective as doxycycline. Rifampicin of 600 mg or 900 mg versus doxycycline 200 mg daily for 7 days was done. Comparison was done by Watt et al. In 2000. And he concluded rifampicin superior to doxycycline with faster differvescence, fewer relapses, but trial was in a geographical locality where doxycycline resistance was known to occur. Levofloxacin versus tetracycline, Tsai et al. Did a study in 2000, did a retrospective analysis in 2010, and he concluded saying levofloxacin as effective as tetracyclines, longer time of differvescence with levofloxacin, higher mortality with levofloxacin in severe diseases. So what he concluded was levofloxacin had a higher mortality. So these were the few trials, last being in 2010, done in the treatment comparison studies with azithromycin versus doxycycline or rifampicin doxycycline or azithrodoxy. But the latest trial which has shown significant difference is the INTREST trial comparing intravenous doxycycline, azithromycin or both for severe scrub typhus. So this is a multi-center double-blinded randomized control trial in which they have compared a combination of doxycycline and azithromycin along with doxycycline alone as another group and azithromycin alone as another group. Total 3 groups. They had subdivided patients equally and they did a study. And let us see what their inclusion criteria was. Patients who were 15 years of age or older and had a positive result on a lateral flow assay of a whole blood sample or an SCAR were screened for eligibility at 7 participating hospitals. Patients with severe disease and the involvement of at least one organ that led to intravenous treatments were enrolled. The exclusion criteria were treatment with doxycycline, azithromycin or chloramphenicol for more than 24 hours within the 3 days before recruitment. Pregnancy or breastfeeding were excluded. Treatment with anti-tubercular therapy because rifampicin has activity against Otsutsukga mushi, those were excluded. Documentation of immune suppression, those patients were excluded. Treatment with contraindicated concomitant drugs and any previous adverse reaction to a trial drug. Now, how they did this drug is they kept the treating physicians and all the treating team, and even this was funded by the WBT. Not sure of the funding, but definitely not funded by any pharma companies. So all the pharma manufacturing companies were also kept in blind. The treating physicians were also kept blinded, and they had used the placebo in the infusions of multivitamin injections to make sure all the subset of patients received equal number of infusions irrespective of the group. So the characteristics, now what are the patients, how they distributed. So if you see the median age and the coexisting comorbidities are diabetes, systemic hypertension, cerebrovascular diseases, all subset of patients with all coexisting illness were equally distributed without any bias, if you can see here. And also the complications, the patients with all the complications, only here we can see the hepatic complications and patients with abnormal sensorium were a little lower, and also renal AKI patients were little lower when seen in the combination therapy group, whereas other complication groups, all the numbers were equally distributed except for the hepatic, renal and neurological manifestation groups. Now, coming to the primary outcome of this study, what they found was the combination therapy had a significant difference when compared with doxycycline alone or azithromycin alone, with a difference of minus 13.3 and minus 14.8, with the primary outcome being composite of death at day 28, with persistent complications at day 7 and persistent fever at day 5. So this percentage was very significant, and with a significant p-value of less than 0.001 with the azithromycin group, and when compared to the doxycycline group, it was less than almost 0.002. So this is a significant difference, showing that the combination therapy had definite effect, positive effect in the primary outcome, that is composite of death at day 28 or persistent complications at day 7. However, in azithromycin versus doxycycline, there was no significant difference in primary outcome were seen. So, but coming to the secondary outcomes, there was no significant difference in any of the secondary outcome when, if you compare with the number of mechanical ventilation days or requirement number of inotropic supports or number of dialysis days or ICU stay. All these days were equal or had no effect in either of the groups. Or means they had all similar results in the secondary outcomes, be it in the number of mechanical ventilation days or inotropic support or dialysis days or ICU stay. The secondary outcome results were not that significant, but the primary outcome had a significant impact when compared with combination therapy versus doxy or azithro alone. So if you can see in this forest plotting, there is a significant difference in combination therapy in percentage points when compared with monotherapy. So what is the conclusion of this trial? In severe scrub typhus, combination therapy is superior to monotherapy with either drug in respect to primary composite outcome of death at day 28, persistent fever at day 5, and reduced incidence of persistent complications at day 7. These are the primary outcomes which had significant difference when compared with monotherapy. And also complications requiring organ support, example, ventilator assistance, supplemental oxygen or dialysis, number of ICU stays were same in all the groups. Now, why combination therapy? Both doxycycline and azithromycin inhibit messenger RNA translation at the bacterial ribosome. Azithromycin binds to the 23S RNA of the 50S ribosome subunit at the polypeptide exit tunnel, and doxycycline prevents the amino acid transfer RNA binding to the 30S ribosomal subunit. The combination of the two drugs may result in a more complete blockade of protein synthesis with a consequently greater effect against Otsutsuramoshi. A better bacterial control during the critical first week of infection may result in prevention and faster resolution of severe manifestations of illness. Now, see, as I said, this is the mechanism of action of azithromycin. They inhibit this 50S messenger RNA in the 50S ribosome, and doxycycline inhibiting the amino acid transfer RNA binding the 30S RNA, 30S ribosome. So that is the mechanism of action. Now, so coming to the treatment, for mild cases without any organ failure, complications, doxycycline 100 mg twice daily for a period of 7 days should be the drug of choice. Chloramphenicol 500 mg QID for 7 to 15 days or azithromycin 500 mg OD for 3 days are effective alternatives. Rifampicin 300 to 450 mg twice a day for 7 days can also be used in patients with mild scrub typhus. For severe scrub typhus cases with multi-organ failure or combinations or complications, combination therapy of azithromycin and doxycycline is found to be superior monotherapy and is recommended as per the latest INTREST trial published in the NEGM. Management of the individual complications should be done as per the existing practices. In pediatric groups, doxycycline in the dose of 4.5 mg per kg body weight per day in 2 divided doses for children below 45 kg. And the use of doxycycline was previously thought to be relatively contraindicated in early childhood, but the consensus of this recommendation has changed and such use is now considered to be reasonable in children under 8 years of age, especially in the context of life-threatening diseases. Or azithromycin in the single dose of 10 mg per kg body weight for 5 days. Pregnant women, azithromycin 500 mg in a single dose for 5 days. Azithromycin is the drug of choice for pregnant women as doxycycline is contraindicated. Now that we have concluded with the management part, now coming back to our case scenario, the main highlighting points in that case scenario were farmer by profession, fever of 10 days, scar had vertical rashes all over the body, and she developed infiltrates which worsened after 2 days with the worsening of altered mental status and worsening hemodynamics breathlessness. So our first differential initial provisional should be a tropical diseases, which again with a stepwise approach, we should consider all the differentials like leptospira, dengue, malaria, and all has to be ruled out with whale felix. And again, coming to the management part, as I just discussed, because she has all the complications, she is suspected to have, if you conclude and come to a diagnosis of scrub typhus, the ideal management would be with the combination therapy of azithromycin 1 gram OD on day 1, followed by 500 mg OD for next 6 days, and doxycycline 200 mg twice daily on day 1 and 100 mg twice daily for the next 6 days should be recommended as per the trial. So what are the key points that we have discussed? Is scrub typhus is a re-emerging infection and outbreaks have been reported all over the country. It poses a diagnostic challenge. High index of suspicion is needed. A detailed history and physical examination is necessary. Specific investigations like whale felix, IgM, ELISA, again PCR technique, IFA. Again, as we discussed, IFA and PCR are more ideal choices of investigations, but they have their own limitations, like they cannot be done at all centers. So still whale felix can be considered as a choice of investigations in a resource limited settings, provided they are correlated well with the clinical manifestations. A combination therapy is superior to monotherapy in complicated or severe scrub typhus. Management of the individual complications should be done as per the existing practices. Thank you. Thank you, sir. Sir.